So now what I'd like to do is introduce our next speaker. And you guys are all energized now. And we sort of did this by mistake. Dr. Alon Avidan is going to put you all to sleep now. Because he is an expert at UCLA in the Sleep Disorders Center. That was a joke. That was a joke. Seriously, Dr. Avidan is professor of neurology at UCLA, where he serves as director of the UCLA Sleep Disorders Center and director of the UCLA Neurological Clinic. And I would imagine that pretty much everybody in the audience today and in cyberspace can really use this information because sleep is so important to your disorders and yet so hard to come by. So he's really not going to put you to sleep. He did complete his neurology residency at Georgetown University Medical Center, where he served as chief resident. After residency, he completed a fellowship in clinical neurophysiology and sleep disorders at the Cleveland Clinic Foundation. Dr. Avidan was principal investigator of a National Heart, Lung, and Body and Blood Institute NIH Sleep Academic Award. He developed key educational modules for teaching sleep topics, which have been adopted by the American Academy of Sleep Medicine. He has published over 100 chapters, letters to the editor, and peer-reviewed articles. Since 2004, he has been awarded Best Doctor in America description. In 2013, he received Super Doctor's distinction, which is given to the top 5% physicians within the respective state or region. He is president-elect of the California Sleep Society. Clearly, Dr. Avidan rarely needs to sleep himself. So with that, I would like to hand the mic to him and let him talk to you about sleep disorders.
Thank you so much. Maybe we can dim the lights a little bit because I want to make sure that you can all take a nice power nap right now. But it's really a pleasure to be here. Thank you, Dominic, for inviting me and for the very gracious introduction. My last name is actually Avidan, but most patients call me Dr. Avidan, which actually works pretty well if they have insomnia. So my job right now is to give you some, a journey through some of the major sleep disturbances that affect patients, and I would like to make sure that if you have any question, that you interrupt me. Just raise your hand. We'll make this interactive. I'm not here to just give you all the science behind the sleep disorders, but really to make this fun, interactive, useful, practical, and hopefully have you be able to ask your physicians, your clinicians, more about sleep disorders, because you know what? The average physician in the United States gets about 2 hours of sleep medicine education, in which they're required to use this knowledge to diagnose, manage, and treat conditions like restless leg syndrome, insomnia, sleep apnea, narcolepsy, and that's just not enough information within 2 hours to really be able to provide this information. So let's go ahead and start. The hour right now, it's just about 1:30 p.m. And looking at the alertness curve, the wake propensity, it's nice, Dominic, that you gave me this hour, because this is when your circadian clock has that dip in alertness. So when everyone goes to Starbucks just around 3 p.m., that's actually physiologic. Because folks in South America, in Europe, they go and take a siesta, right? Here we go and get to Starbucks. And just around 9 p.m., we have our second wind. We all get a lot of energy. And just around 9 p.m., right after 9 p.m., the brain secretes melatonin, and melatonin shuts the circadian clock in the brain. And that's useful, because that's a good signal for the brain to start preparing for sleep. All right. Now, why am I showing you this? Because if you look at major accidents that have taken place in history, like the Exxon Valdez, Chernobyl, single car accidents, they take place really very interestingly just around the time when the wake propensity is at its lowest. That's a selectively vulnerable period in which we're all feeling sleepy. Just right when we wake up in the morning, just after between the hours of 6 to 8 a.m., and just after midnight. Now, physicians who are on call, if you go to the emergency room and you have to go in between the hours of 12 a.m. all the way to 8 a.m., you're likely to see sleep-deprived physicians who are going to go on very few hours of sleep, and that's why in 2003 and also in 2011, there were modifications to the work hour schedule for physicians, knowing that this is a selectively vulnerable period where they're likely to make mistakes. Now, why are we talking about this? Because we all know the consequences of sleep deprivation. Sleep is irreversible, it's biologically necessary, it's important for our ability to store information, get rid of material in the brain, proteins that are not necessary. There is a new theory about the evolutionary need for sleep, and what we're finding is that during sleep, there is a circadian increase in cerebrospinal fluid flow that takes away from the cells all kinds of garbage and material that the cells do not need. And if you do not get enough sleep, the concentration of that material tends to increase and puts people at risk for considerable medical problems, and in laboratory animals, even the accumulation of proteins that are found in patients with Alzheimer's disease. The alpha E4 phenotype that's been shown in Alzheimer's disease. Now, we all know that sleep problems increase with age, and that's probably related to the underlying comorbid medical problems that tend to increase with as we grow older. And we know that the architecture of the sleep stages also changes. Specifically, patients go through less restorative sleep. They go through less REM sleep. REM sleep is rapid eye movement sleep, and you need that for dreaming and memory consolidation. And also we find that the total amount of time in sleep that the patient actually sleeps is reduced compared to a younger individual. All right. Let's now go and discuss and describe the major sleep disorders. Let's start with obstructive sleep apnea. Why do I put this first? Because sleep apnea is probably one of the most common sleep disorders, and secondly, one of the most dangerous sleep disorders that we should never misdiagnose and undertreat. Sleep apnea, if it's severe and it doesn't get treated, can lead to motor vehicle accidents. It can lead to cardiovascular problems, arrhythmias, specifically stroke, high blood pressure. It can increase a hormone in the brain that increases weight gain, and it's a vicious cycle. Most people who have sleep apnea tend to have an increased resistance to airflow because they're overweight. And if you have sleep apnea, you're more likely to be sleep deprived. You're likely to produce this hormone that is going to make you hungry, and you're going to increase weight. Who are the patients with peripheral neuropathy who have, or other neurologic disorders that are at risk for obstructive sleep apnea? Well, the first one is amyotrophic lateral sclerosis. That's actually the #1 reason why we see these patients in a sleep clinic. The brain has an area in the brainstem where the breathing cycle is originating. And that's in the area in the brainstem actually is a stimulus for the control of breathing. And we know that patients with both strokes that affect the brainstem as well as issues related to amyotrophic lateral sclerosis can give you central sleep apnea. So you cannot breathe, and your brain doesn't send you the signal to breathe. But the most common problem that we see in our sleep clinic at UCLA related to sleep disordered breathing is obstructive sleep apnea. And I'll show you a patient. You notice that he has snoring. Now, the video is not working 100%, but what he's doing, he's really struggling to move air across a closed airspace. You notice that right now he stopped breathing. That's called an apnea. And apnea is a period where the air doesn't go through. It doesn't reach the lungs. The oxygen doesn't get the oxygen doesn't reach the brain, and it doesn't reach the heart, and that's a stimulus for an arrhythmia. And hopefully he's going to start breathing again. And when he starts breathing, that's a resuscitative breath. And here we go. He started breathing again. And this is just one example of a single apnea. The vast majority of our patients have 50 episodes like this per 1 hour of sleep. You need 5 to have obstructive sleep apnea syndrome. Why is this problem not going away? You all know about the obesity epidemic, and this is the statue of David before departing to America, and this is when he returned. So, you know, this is a problem. And many of my patients come in, and of course, they don't necessarily exercise healthy eating habits, and we need to send them to nutritionists because weight loss, especially after bariatric surgery, is related to significant improvement in the severity of sleep apnea. Now, the vast majority of patients, as I mentioned, have a reduction in the airflow right here in the area where the tongue and the soft palate come in contact. That's called the vilopharyngeal airspace. And the sleep apnea, when you look at the sleep study, you can see that the patient doesn't have any airflow, and they're trying to generate effort. Their muscles are really working hard to push air against a closed airspace. One thing that you notice here is an arousal. This is actually looking at the electroencephalogram. These are brain waves. And here we see an arousal. The patient actually wakes up. The brain wakes up. The patient may not know that he or she are waking up, but when they wake up in the morning, they're never going to feel refreshed. The vast majority of these patients are as sleepy as patients who have slept maybe 2 or 3 hours during the night, and they don't know why. They know that they're choking at night. They know that they're waking up with a headache. They're never refreshed. And when we hear about snoring, choking, middle of the night awakening, daytime sleepiness, that's a red flag that we need to look and assess the patient for sleep apnea. Now, the best treatment is using positive pressure therapy. This is continuous positive airway pressure. And what the pressure does, the air pressure essentially splits the airways open very nicely. And you can see going from 0, 5, 10, and 15 centimeters of water. When we push air through a closed airspace, we are expanding the airspace very nicely, reliably. This is really the gold standard of therapy. I often see patients who undergo surgery, like uvulopalatopharyngoplasty, where the surgeon promises that after they have the surgery, they're going to get rid of the sleep apnea. In my experience, in 2 years, 2 to 3 years down the road, the patient comes back with the same symptoms. If this is a child or a younger adult and the sleep apnea is related to enlarged tonsils, surely we can improve the sleep apnea. We can actually correct it by removing the tonsils. It doesn't hold true in adults and older adults with more significant comorbid conditions. Now, the CPAP unit is composed of a pressure generator, a tube, and a mask, and it essentially works, the box, the CPAP battery and the housing unit that generates the pressure is probably half the size of a shoebox. When you go to the airports, you may hear TSA telling people to put their CPAP machines out, go through the security line. And it's amazing how many times when I fly, I hear that, because now we know that this is really an epidemic. Sleep apnea really has reached an epidemic proportion. 3% in men over age 18, 6% in women. After age 65, it doubles. But it may not have the same implications, interestingly, but in patients who have cognitive dysfunction, memory problems, it certainly needs to be treated. Now, I want to show you, this is a hypnogram, and it shows essentially what happens to oxygen as the time of night goes by. This is around 11 p.m. Here the patient wakes up at the very end of the morning, and you can see that the oxygen is very, very low without CPAP. And once we apply CPAP, the patient has normal oxygen, and you notice that they're beginning to go through REM sleep. They're beginning to dream again. That's called REM rebound. You know, after, let's say you go without sleep for 1 or 2 nights, when you recover, you have very vivid dreams. That's actually a byproduct of a REM sleep rebound. And many patients wake up the following morning after undergoing a CPAP titration in our laboratory and telling us, wow, I didn't know I had so many dreams. That's the first time I've dreamt after 10 years. And the stories are quite dramatic. The problem is that many patients are not very compliant with their CPAP. There is about 50% compliance. We really need to work and change the image. Most patients tell me they look like Darth Vader when they use the mask, and we tell them, don't worry, you're gonna look like an F-15 fighter pilot, and we try to change the image, get the bed partner involved, maybe change the mask to a smaller nasal mask. That sometimes helps improve the claustrophobia and allows the patients a lot more mobility. If you or you know about relatives of yours or friends who use CPAP and they can't tolerate the mask, we at UCLA, for example, we achieve close to 80 to 90% compliance because we have a CPAP fitting clinic in which a dedicated technician works with the patients and makes sure that the mask is comfortable and it's custom fit and really provides them with the most effective mask to their facial features. You know, using a CPAP mask is like trying a pair of jeans. You really need to go through multiple masks to really find the one that's most comfortable. Over the last few years, we've also heard of mandibular positioning devices like dental appliances that can be used to treat patients who have snoring and milder degrees of sleep apnea. All right, let's move to insomnia. Now, insomnia I mentioned that sleep apnea is common. Insomnia is even more common. Up to 30% of all Americans have insomnia at any given time. Just gonna have a drink of water. Insomnia is essentially difficulties initiating sleep, maintaining sleep, or early morning awakening for 30 days or longer. And essentially, what you have to have is a patient who complains of insomnia for 2 to 3 days per week up to about a month. That qualifies them as clinical insomnia. So I mentioned difficulties falling asleep. That's called sleep initiation insomnia. Difficulties maintaining sleep, and early morning awakening. People used to call early morning awakening terminal insomnia. And then I used to have a lot of patients coming really worried and having worse insomnia because someone told them they have terminal insomnia. So terminal insomnia doesn't exist. It's really early morning awakening, but they have to have next day consequences. What does that mean? Well, memory problems, depression, driving on the freeway and missing the exits, going to the supermarket and forgetting what brought you there, or forgetting to buy items because you don't remember them, and difficulties with psychosocial function. If you have daytime consequences, that's clinical insomnia. So if a patient has difficulties initiating sleep, it could be related to restless leg syndrome. How many of you have heard of restless leg syndrome? Can I see a show of hands? Very good. This is the one condition that is specifically related to peripheral neuropathy because it often gets confused from peripheral neuropathy, but restless leg syndrome is very specific, and I'm going to show you some examples. If patients wake up in the middle of the night, it's generally related to an underlying primary sleep disorder like sleep apnea, periodic leg movements, and also poor sleep environment. Early morning awakening is usually depression until proven otherwise, but it could be related to certain medications and also related to circadian rhythm, especially abnormalities that we see in older adults where they go to sleep very early in the evening, like 8 or 9 p.m., and then they wake up at 4 a.m. where it's too early. There's no one to talk to at this time because no one's awake at this so early in the morning. Now, here's the problem with primary insomnia. Primary insomnia is hyperarousal. It's insomnia that's not really related to any other medical or psychiatric comorbidity. Primary insomnia is really something that is very common, and it's usually related to poor sleep habits that the patients have around their bedroom. So here she has a Jack Daniels next to her bed. She has the clock. She has light. She's waking up and she's worried. She's worried about what is she going to do about that deadline that she has to meet. And people, you know, it's amazing how many electrical appliances my patients use just around the bedtime, and they have a compulsion to write emails and do work and using their iPads and go on the news and, you know, wake up. If they wake up at 3 a.m., pick up the iPad, turn on the TV, hear about, you know, the news lately is not terribly encouraging. So, you know, this is going to put people even more, make them more anxious. And this is the worst thing. You know, I was flying Delta Airlines one day, and I noticed that they were selling this table that patients can bring over to their bed to put the laptop. They have a coffee mug area right here. And I'm saying to myself, how in the world is this going to be useful to my insomnia patients? And of course, the light from the television, the light from the iPads and the computer screen is stimulating the circadian clock in the brain, and it's going to cause even worse insomnia. Now, let's talk about hypnotics. Hypnotics are any medication that is used to help patients fall asleep. The vast majority of my patients, before they come in and get treated for insomnia, they tell me that they have tried alcohol. Alcohol is very enticing because it makes you feel sleepy. But there is a problem. What happens when you fall asleep? You stop drinking. And that's a problem. Because I'm going to show you, this is a sleep diary of one of my patients. Went to bed at 7:45, fell asleep at 9:45, woke up at 11, he had scotch. Fell asleep at 11:30, woke up at 4 a.m., he had another scotch. He crossed it out, but I think he did have it. And then he fell asleep at 4:15, woke up at 5:24, had another scotch. So, you know, the half-life of alcohol is about 2 to 3 hours. So it doesn't really work very well in maintaining sleep. And plus, it has an abuse potential. It destroys the sleep architecture. It really gets rid of REM sleep. So when you wake up, it rarely feels refreshed. Instead, we have multiple medications that are called the Z drugs: zolpidem, zolpidem, esapicolone. This is Ambien, Sonata, and Lunesta. We have one melatonin agonist, and we have one sedating antidepressant that have currently been approved by the FDA to manage insomnia. And what we do is we try to match the half-life of the medication to the timing of the insomnia. So for example, Sonata, that's zolpidem. Sorry, Sonata is zolpidem, 1 hour half-life. We call Sonata Sonapa. It gives you a nap. And on the other hand, we have a medication like flurazepam, which has a 100-hour half-life. And it's FDA approved for insomnia, by the way. So, you know, we never use medications that have longer than 6 or 7 hour half-life because we don't want residual problems the next day. So drugs like esapicolone, 6 to 7 hours, that's Lunesta. But recently, the FDA has sent warning about asking physicians to lower the drugs, especially in patients over age 65 and in women, because next day impairment, especially when driving. So if you are on these medications and you're using a high dose and you notice daytime sleepiness, that's a good rule of thumb to maybe speak with your doctor about lowering the medication. Let's move to restless leg syndrome. The new name for restless leg syndrome is Willis-Ekbom disease. It's named after the two neurologists who first described it back in the 1700s and 1800s, I actually prefer that term. I'll tell you why. Restless leg syndrome is a misnomer. The first thing is that when people are looking for restless, they're not going to necessarily find it. Patients who have restless leg syndrome have an urge. First of all, they may have restlessness, but the urge is more important. The second thing is legs. If a physician is looking for restless legs in the legs and the patient describes restless legs in the arms, they're going to say this isn't RLS. So it's a misnomer. With many patients, as the disease progresses, we have patients who also have RLS symptoms in the hands, in the chest, in the abdomen. It's not solely confined to the lower extremities. The third thing is syndrome. A syndrome is a term that we use when we don't understand the disease mechanism. For restless leg syndrome, we do. We actually have a genetic basis. We know that many of these patients have iron deficiency. Dopamine in the brain may have some role to play with it, but it is certainly a condition where the brain, cerebrospinal fluid, iron metabolism is impaired. And that's why iron supplementation often works for this condition. I'm going to show you a patient with restless leg syndrome. The only thing that really worked to control his restless leg syndrome was to take a baseball bat and to hit his legs with the baseball bat. He did that every single night before going to bed when his RLS symptoms were bothering him. We told him that there are actually 4 FDA-approved treatments that he could use instead. But you know, the one thing that's really interesting is that for a lot of these patients who have such a significant symptomatology, if they induce pain in the affected limb, it actually gets rid of the RLS. But it would leave them with a pretty significant bruise. So we try to, as much as possible, for the patients with moderate to severe primary restless leg symptoms to use one of the 4 FDA-approved treatments. And here's why it's important. Because restless leg syndrome is often misclassified, let's go over this differential diagnosis. The first one is the easiest one to differentiate. It's called nocturnal leg cramps. Nocturnal leg cramps are nocturnal, so that may be confused with RLS, but instead, with nocturnal leg cramps, the patient has a very, very painful muscular contraction affecting the back of the leg, the gastrocnemius muscle. It's confined to this muscle. The muscle contracts. It's feeling like a spasm, pain, contraction, like a Charlie horse in the middle of the night. It's not really the urge to move, it's the pain. Second thing, claudication. Claudication is really related to a peripheral vascular disease. With a claudication, when the patient starts moving, the condition gets worse. With restless leg syndrome, as soon as the patient moves, it gets better. The symptoms get better. Okay? The other thing, ecastasias. Ecastasias are described as an inner body restlessness, usually seen in patients who are using antipsychotic agents. And it doesn't have a circadian pattern. One thing that is very critical in RLS is that the symptoms are 24 hours, but they generally get a lot worse around the evening time. And that's another differentiating factor from peripheral neuropathy. The urge to move gets better in peripheral neuropathy, but it doesn't have the circadian predilection that we see with restless leg syndrome. Now, we can have patients who have both RLS in the setting of peripheral neuropathy, but the two conditions sometimes overlap and sometimes make it very confusing for the clinician to differentiate. But the good news is we have treatments that are effective for both the RLS and the peripheral neuropathy, so they get one medication for both conditions, which makes it a lot easier. Now, one thing to remember about looking for RLS is that there is a mnemonic. There is an urge mnemonic. U stands for the urge to move the limbs. R, rest or inactivity usually makes it worse. G, getting up and moving, gets rid of it. And finally, E, there is evening predilection. The events usually get a lot worse in the evening time. There's another condition. It's called peripheral neuropathy, periodic limb movement disorder. 80% of patients with restless leg syndrome also have repetitive movements of the legs or the arms during their sleep cycle that is interpreted as a jerk by the bed partner and usually leading to insomnia or excessive daytime sleepiness. The treatment for periodic leg movements is similar for RLS, but the question is, many physicians confuse the two terms. Restless leg syndrome is a clinical condition. Periodic leg movements is a sleep study condition. You need a sleep study to really make the diagnosis. As I mentioned, there are treatments available. There are 3 dopamine agonists that we use to treat RLS. They include rotigotine, pramipixole, ropinirole, and one recently approved alpha-2 delta ligand, that's gabapentin and acarbol, that is called Horizon, available as a trade name Horizon. Now, pregabalin was recently documented to also be very effective in patients who have RLS in the setting of painful peripheral neuropathy. There are also some conservative treatments that are very effective. Alerting activities like a patient playing chess before going to bed actually works very well for some of these patients. I have one patient who tells me when she argues with her husband, the RLS disappears completely. I tell her to use discretion, maybe try not to argue too much, but she swears this is the one thing that always helps her. Let's move to narcolepsy. Narcolepsy is a type of central nervous system hypersomnia where the pathology for daytime sleepiness is really in the brain. The condition is really exemplified by severe daytime sleepiness despite appropriate hours of sleep. And we have what we call REM sleep phenomenon. And that one example is cataplexy. And I want to show you an example of cataplexy. So the patient is startled with a surprise or laughter, and immediately they experience loss of muscle tone. They have unbuckling of the knees. They can't really sustain muscle tone. And even the anticipation of hitting a ball is enough to trigger a cataplectic type event. So there is a loss of muscle tone triggered by a strong emotion or anticipation of a game or an event that's going to be very stimulating for the patient. So you can imagine how detrimental this is for their social life. I had one patient when I was at the University of Michigan who, he worked at the hospital there, and he would never go through the major hallways because whenever patients asked him for directions, he would have a cataplectic event. So he always went through the back doorways and the hallways in the back to avoid that interaction. So he essentially was trying to avoid, how can you live your life avoiding these social interactions? But the good thing is that there is very effective treatment. Usually antidepressants work very nicely for cataplexy. And for the management of daytime sleepiness in narcolepsy, we have drugs like Nuvigil, Provigil, and sodium oxybate. I'm going to go now to the parasomnias, maybe about 2 minutes. Dominic, how are we doing on time? 2 minutes is okay? Perfect. I'll do it in 1 minute. There's one parasomnia that I want to tell you about. It's called REM sleep behavior disorder, and here it is in a dog. Well, the dog is not cooperating. Let's move to a different patient. The videos worked on a Mac, but they're not working on a PC. So I'm going to show you. Very interesting. A patient came to see me a few months ago, and they brought a set of the patient brought a set of handcuffs and told me this is how he goes to sleep every night. Because if he doesn't, he tends to act out his dreams. And he has what's called the REM sleep behavior disorder, very aggressive dream enactment, where the patients can get such severe injuries that really this is requiring treatment with drugs like clonazepam and melatonin. And really, the videos unfortunately didn't work, but they are fighting at night, they're very aggressive. They're actually fighting and enacting whatever their dream content is. Usually, when we're dreaming, our muscle tones are supposed to be flat, but in these patients, the muscle tones are very active, so they're running, yelling, screaming, patients playing soccer, hitting their spouses in the process. And this patient that I showed you, she actually was attacked by bees, and she flew over her dresser and suffered a basilar skull fracture. So I'm just going to conclude here. I hope I gave you, a brief journey into some of the sleep disorders that we are likely to encounter in any patients, but specifically in patients with neuropathy as related to restless leg syndrome. The important thing is sleep disorders are unrecognized, untreated. We need to look for them. We need to screen for them. And if your doctor, if you're a patient and you mention this to your doctor, make sure that he or she refers you to a sleep physician to get a little bit more assistance, a little bit more help, because when they're treated, it's wonderful. The quality of life improves, and it's very gratifying to take care of these patients from a clinician standpoint. So thanks for inviting me, and I appreciate it.
Yeah, we can take a couple of questions, and we need to repeat them for people that are in cyberspace. Go ahead, you've got one here.
Okay, what are the long-term effects of using Adderall for sleep apnea? And the other one is you never experienced REM sleep or dream sleep after you started sleep apnea.
Yeah, you need to repeat his question.
Yeah, so the first part of the question was about the safety and the issue of using Adderall to treat sleep apnea. There are no medications to treat sleep apnea. The treatment of sleep apnea is really focused on managing the airway restriction using CPAP. Now, people have used wake-promoting agents like Nuvigil to treat excessive daytime sleepiness in the setting of sleep apnea that is treated. Adderall is actually a stimulant, and I would be very concerned about using a stimulant in someone who has sleep apnea because of the potential for elevations in blood pressure, pulse rate. It's an easy drug to get, it's cheap, it's inexpensive, but the side effect profile probably doesn't justify to use it as in any type of patients. Now, if the modafinil and the armodafinil are ineffective in some patients who have had an EKG and have had arrhythmias rolled out, there may be some role, but these patients really need to be followed carefully. Yes? The question is about ASPS. ASPS stands for Advanced Sleep Phase Syndrome, and it's related to a circadian abnormality usually seen in older adults who have early bedtime, usually around 8 p.m., and then wake up at 3 or 4 a.m., and they usually suffer from insomnia in the early part of the day, of the morning. The treatment for this condition is using light therapy in the evening time and simulating sunlight. You need to use about 10,000 lux. You can get this light therapies on Amazon. They're light boxes. They cost about $70 to $80. And they emit high intensity, bright light spectrum of light that can be very effective in readjusting and resynchronizing the circadian disorder. Sure.
Okay, let's take 2 more questions back here.
Yes.
Purple shirt.
So the question is how to manage a patient who has chronic pain, who has middle-of-the-night insomnia, who's waking up frequently complaining of chronic pain in the middle of the night, right? So we generally, there are no specific FDA-approved treatments for hypnotics that have dual efficacy in controlling both sleep duration as well as a neuropathy. So most of the drugs that we use in sleep medicine are medicine-based evidence as opposed to evidence-based medicine. So what we do in this condition, again, it's off-label, but we use drugs like pregabalin or gabapentin. They're usually alpha-2 delta ligands have good efficacy in improving sleep continuity, first thing. Secondly, they're also effective in reducing the arousals during the night. The third is that they improve delta sleep, which can be disrupted, especially in patients with fibromyalgia. And the third is the pain control. You only have a problem with how to avoid daytime sleepiness, because many of these drugs, as you know, cause significant degree of hypersomnia or excessive sleepiness the next day. One more question? Yes. The question is about the correlation of neuralgia paresthetica and restless leg syndrome and periodic leg movements. The first thing is that patients who have restless leg syndrome may have an underlying peripheral neuropathy, so there may be a comorbidity. The one important thing with neuralgia paresthetica is that it usually can be differentiated from restless leg syndrome by the general absence of a circadian worsening in the evening time, and it can be differentiated by the fact that when patient starts moving, it doesn't always get better. With RLS, it's almost universally getting better. But there are patients who have both conditions, and of course that makes it a little more difficult to differentiate. All right? Thank you so much.